So, hello everybody. So we got 1 or 2 minute delay before the presentation starts. So maybe I can first thanks CERCare, Professor Ostergaard, Mr. Ostergaard, all the CERCare team for inviting me for the 2nd year in a row to talk about CBCT perfusion. As you saw, there's also Professor Johannes Kessmacher that will do a talk this afternoon. These will be complementary talks, so we'll try not to overlap. So all the talks you've seen this morning will be probably approached by our 2 presentations. We will share a bit pre and post-stroke perfusion, and thank you. And so, as I was talking with you about Johannes Kessmacher, we are very complementary because he's a Siemens user, I'm a Philips user. He's probably using perfusion for much more time than me. And so we will be very complementary. Last year, my background of the presentation was white. I was really, really enthusiastic. This year, it's just a summary of my last year, and I choose a very darker background. Not that I'm not optimistic, but as you will see honestly in this presentation, I found plenty of issues and difficulties that we are overcoming to try to do as best as CTP. This was my first slide last year, so I just took this one from last year's presentation. As you can see, finally, CBCT perfusion is mainly limited by a very poor temporal resolution. In 1 minute to 1.5 minutes, you can acquire 5, 6 to 10, 12 time points acquisition, and you do your perfusion with that. Also, you got the problem of the CT quality, which is with old machines largely lower than conventional CT. With the new machines, it's kind of better. So we got largely less beam hardening artifacts and also really, really good motion correction. I will try to show you some part of the work that Philips done, probably Siemens done the same, but I cannot show this. So just to begin, I've just selected 4 publications that, to my mind, are really relevant to introduce CBCT perfusion. The first one, there's plenty of studies from Switzerland. So the first one is from Marios Psychogios from Basel and his team. And they evaluated like the gain of time you can have just by using a one-stop in the angio suite and skipping conventional MR or CT. Roughly 29-30 minutes. So you can win 30 minutes, so you can win like 60 million neurons. Sounds kind of cool. So this just a kind of introduction. They were using ArtistQ, which is now not the last release of Siemens machine, but they were still able to provide some good images. Another study, which was also a few years ago, now 4 years ago, from 2 centers of America, from University of Iowa and from Charlottesville. And they just show that also with Siemens, ArtistZ, so even a lower quality machine, you can do this. You can try to analyze some regions and show that there's a decrease in the perfusion and try to evaluate core and penumbra, very roughly. As you see, they were quite able to show that there's a difference in perfusion between fast and slow progressors. This one's more interesting, so I disclose, because this is a study where there was Johannes Kessmacher, but it's probably for me the most interesting study on CBCT perfusion, or one of the most interesting, where they show that this is highly feasible with ArtistQ, and also that there was a very good correlation with a threshold of RCBF that is not conventional, less than 45%, instead of less than 30%, on conventional CTP. So this is the first point I want to explain to you, that probably with CBCT perfusion we have to destroy everything we know about threshold and the mean to assess core and penumbra. This is where exactly all the talks of this morning are super interesting, because probably we can directly skip everything and go directly to what they show. Then also the second interesting point was the correlation, which was not exceptional for showing the mismatch volumes and the penumbra. Actually, everyone's working to try to do better. So far, this is probably the best result published. Another study, also interesting, also from Bern, and this time with artefacts. And they also show that there was a low correlation, weak agreement for core and hypoperfusion, which means probably either we are too much low temporal resolution, or either we have the wrong mean to assess the core and the penumbra actually. This was the first case in Reims we've done now more than 1 year ago with Cerker to assess the perfusion on the angio suite. So, as you know, in France, we are really, really fond of MRI. So, the place of the CTP and CBCT perfusion is mainly to reassess patients when there's a delay between MRI and the arrival in angio suite, or just for research. So in this case, you got the MRI, left M1 occlusion, left M2 superior stroke. Probably the posterior branch is still not suffering so much. M1 clot. Here is the maps we acquired. And as you can see, we got the conventional maps. We also got the advanced map provided by Cerker software. What we can see here is that finally, there's not such a big mismatch, probably, with a CBF that is quite similar to the Tmax, not completely similar. OEF is very high. The patient is still at 6 hours from symptom onset with a very, very high disability. What I wanted to show you is this slide. As you can see, depending on the CBF threshold you choose and the Tmax threshold you choose, you can make the maps say whatever you want. So finally, what's important is that if you use the threshold from the Bern study, less than 45%, you got twice less mismatch volume than the conventional CTP threshold. This is the first point. We stay with the Tmax 6 seconds, the conventional one. We do the thrombectomy just with a single aspiration. The clot is here in purple. In blue, the catheter. We remove it. And we are kind of happy because on the angiogram, you can see on the lateral view that almost all the parenchyma seems to be visible, which for us, interventionists, seems we are believing that there's few dead tissue. Finally, you see we saw an improvement of the patient, but not so big, like the patient gained 6 points over 16. So it's kind of good, but it really reflects what we saw earlier when we had this. And finally, we believe that there was not a lot of salvageable tissue. So as you see, it's a bit rough compared to CTP or MR perfusion. It's a bit preliminary, but it still works. I'm showing you a more recent case with a tandem occlusion, so that you can see there's a very, very small M2 clot into the right insula, causing this stroke, and you got also an occlusion of the carotid. It happens sometimes. The patient went in 2.5 hours. It's super long. You have to deal with that. So what we've done, non-contrast CT, CBF, Tmax, this is maps derived from General Electric scanner and workstation. And you can see there's still a huge mismatch. 15 minutes later, as I'm very curious, we also done a CBCT perfusion. So we can compare within 15 minutes. And what we see is really interesting. It's almost the same that we've done with CTP. We are seeing that there is dead tissue, but most of the sylvian anterior and posterior part are still salvageable. And the 24-hour CT is largely the same as the diffusion after recanalization. So finally, we were kind of well predicting the outcome even with CBCT perfusion. And you see it's almost the same as the CTP done 15 minutes before. But sometimes there's a darker background. So we got some issues sometimes. And as you see this patient with M2 occlusion, I'm showing you the CBCT. And okay, we can see there's something, but you can see there's a lot of artifacts. And we were here not able to know where it comes from. And we observe this not only on this case, but sometimes. So it's a bit annoying actually, because we don't know where it comes. I will give you some small ideas about where it comes, but I'm not sure actually. So my practical feedback is that if you want to succeed in this kind of perfusion on CBCT, every detail counts. It doesn't mean you need a Ferrari, but you need to be as precise as the Ferrari team. Meaning, if you got someone that forget to remove the earrings, you're fucked. If someone forget to remove a piercing, you're fucked. If you cannot optimize the head environment, like if you got someone under general anesthesia with plenty of probes, tubes, okay, you got also to firmly secure the head to ensure the patient doesn't move. It seems very, very basic, but at 2 hours in the morning, if you don't do that, you will have no CBCT perfusion to interpret. Also something which is interesting, the headrest and the gels you put to make the patient comfortable. It decreases the quality of the CBCT. So don't be so kind with the patient. It decreases the quality. And then something I can just talk about for Philips, but we've observed that if you don't do your technicians don't do the calibration of your machine every day, every morning, in less than a week, you can decrease your CBCT quality image by more than 30%. You got some artifacts that are coming, linear artifacts like you saw. Sometimes it's a target artifact in the middle of the scan. So you have to do this and to ensure your people absolutely do the calibration every day. And then train your staff, because when you are at 3 in the morning and there's someone that doesn't remember exactly what to do, you have to train them not just once, but like 4, 5 times, so they are really strong and can do it every time. So finally, you don't need the Ferrari, you need the Ferrari team. The specificities of Philips is finally, I show you on the first slide some details. If I go briefly, they do less than Siemens. They do less rotations. The rotations are more spaced from time, the time space is larger. And maybe the only thing is with the new release of the Azurion, the image quality is very impressive. So at least we have almost no artifacts now. You got also 3 possibilities to modulate the radiation dose. We will talk about that. You can stay low, normal, or an extra dose if you like to have beautiful images. I'm just showing you images of a butterfly scanner. This is a standard scan, helicoidal. So as you see, the trajectory is not perfectly straight, but it moves a little bit around the head of the patient. So when you got a patient under general anesthesia, you just have to care that one probe don't fall away because of that. But finally, it provides from far better images. The thing is, actually, this kind of scan, even for research, it's an 8-second scan. Siemens is capable to provide a scan in 5 seconds with a very, very shorter delay compared to Philips to start another scan. But at least, yes, 7.8 seconds if we want to be precise. And we got a really better quality here. It's a subarachnoid hemorrhage with a patient with coils into the anterior communicating artery, and you see a conventional CBCT and a CBCT with the butterfly. Here you got some images of my old Azurion machine. We got 2 Azurion machines, one old and one brand new from 2 months ago. This one is a CBCT perfusion from the old machine. And here you got a scan from the new machine. As you see, the new machine provides a scan that is really comparable to CT now. And we were able to win 2 seconds per row, which is kind of good, but not enough actually. What's interesting is this. Siemens is largely capable to do that so far for many years, but not Philips. Now they are capable just to scan alternatively from the right to the left and the left to the right. So this is largely decreasing the time of pause from 10 seconds to 1 second. In the basic scan, you got like 10 seconds acquisition plus 10 seconds pause. Meaning you scan for 10 seconds, it go back to its position for 10 seconds. Actually, we are able to do 8 and 8 with the butterfly. And with this, it's a scan that is actually 8 seconds that you can decrease up to 6. And now we will probably come closer to Siemens with this kind of machine. About the radiations, there's an interesting study. Again, it's from Switzerland and from Basel. That has studied some of the machines. As you see with the Artis Axiom, which is and Artis Q, which are the oldest machine, you got higher dose. On their last machine, they got a lower dose, 4.5 millisieverts without collimation and less than 3 millisieverts with collimation. On our internal database, we've seen that depending on the collimation, but also on the quality of the scan, meaning if you push the X-rays really hard, you will go beyond 4 millisieverts. But if you stay quite on the low protocol, it stays around 2 millisieverts. So it's kind of really, really close to a conventional CT perfusion first, but you got a whole brain coverage compared to the CT perfusion when you got a really, really small coverage of an area. It is just to talk about the butterfly, because I told you it provides better images, but finally what's important is also it increased dramatically the dose. So a conventional CBCT with Philips, it's like 20 milligray per rotation. We can go lower than 15 if we decrease the quality of the image. Meaning, with a conventional butterfly, you're at 40 milligray, and a low-dose butterfly, 30 milligray. So the dose can increase, like if you want to have beautiful image, the dose can increase twice a conventional CTP. But with that, you got absolutely no artifact, and there's some kind of straightforward answer. Oh, sorry. The future applications. So finally, most of the people, of the speaker this morning, you gave plenty of insight about the future applications. So we've seen the direct selection of patients to go into angio with refining the game and changing the parameters for defining core and penumbra, finally mainly looking at CMRO₂, OEF, etc. And we got also a rapid reassessment of the patients. It's the same. The detection of no-reflow, as Ettore spoke, but probably this much more in line with the talk this afternoon. So I will not overlap. The reperfusion injuries, it's much more over parameters. We can also try to predict hemorrhagic transformation. Two interesting things we try to do actually is try to look at vasospasm and the treatment of vasospasm and help for decision making, because when you got subarachnoid hemorrhage, slight subarachnoid hemorrhage, and vasospasm, like you're 10 days after a subarachnoid hemorrhage, so you don't see hemorrhage anymore on the scan. You got a vasospasm, sylvian vasospasm. You dilate the artery chemically, and sometimes you got an improvement, like the artery is twice bigger. Is it still enough or not? We don't know. Should I have to put a stent, a balloon, reopen more the artery? Honestly, I don't know. And we don't know. So what can we do? We can do a CTP. We can search for still microperfusion and macroperfusion impairment, and then guide the treatment, stop or continue. Another thing is the assessment of bifurcation and indirect flow diversion effect. So you put a stent into a bifurcation, like the sylvian bifurcation. You can deploy 2/3 of the stent, and you can have a look at the sylvian territory and see whether or not you got a big impairment in the flow. If so, sometimes it's not visible on conventional angiography, but it's visible with perfusion. If so, you can just remove your stent and don't do this kind of treatment. If everything's perfect, you can do it. Actually, this kind of treatment carry a risk of like 25% of thromboembolic complication, which is far much more complications than conventional treatments. So as you saw on other talks, I've just put one of my old work from 10 years ago to show you that effectively the diffusion lesion is not a perfect marker of the infarct core, as if you recanalize early the patients, like within 4.5 hours, 4.5 hours, 1/3 of the patients can have a decrease in their diffusion volume size. And most of this volume is sustained and saved. Finally, with the Lyon team work, you've already seen these images. With the OEF, it can really help you to know whether or not some diffusion will reverse. So it's also interesting to have all these parameters before doing the thrombectomy, so you know exactly on what you're going on. There's also the study from Alexandre Banissade from Lyon, and there's also a study from Dr. Wu, which is a little bit older and concludes exactly the same, that OEF is a super good marker for DWI reversibility. You've seen already this one from the first talk. Very interesting paper in my point of view. It gives the opportunity to say that probably we are doing wrong with CBF actually to define the core. You see also that MRI is not perfect, so probably maybe CMRO₂, which is a very good gold standard derived from nuclear medicine, can be used directly into the angio suite. Just a case of vasospasm. As you see here, I had a patient with right M1 and M2 vasospasm. The vasospasm was very, very tight on the superior M2 right branch. So you can see there's an impairment into the CBF on the left and the Tmax on the right. There was a little bit of core and penumbra. Finally, we had a quite good improvement after just 30 minutes of chemical dilatation. So as I said, is it still necessary to continue, or can I go back home? I don't know if it's sufficient or not. We redo a scan, almost normalized, I can go back home. procedure is finished. Thank you for your attention.
Thank you very much for this very honest report from the Ferrari, pit stop. That was very impressive and thought-provoking. So, questions from the audience? Otherwise, I have one that sort of includes everything we've heard this morning and what you're looking at here, and that is anesthesia. So physiologically, if we anesthetize patients, we would expect their normal brain tissue to, its CMRO₂ to drop dramatically. And I know that sometimes, you'll have to anesthetize patients. And I'm just thinking in that perspective, you essentially may reduce some of the contrast between sick tissue and normal tissue, because all of a sudden you're in a different condition in terms of CMRO₂ and so forth. So I just wonder if you have any thoughts about, I know patients have preferences with respect to being anesthetized and not, but
First, I absolutely agree with you. When you have the induction of anesthesia, you got a temporary drop of the brain perfusion due to the loss of the drop of the blood pressure. But finally, we are kind of not able to image this, because either you stop the anesthesiologist and you do your perfusion before, or you do it just after. This may provide an insight, because when we do the perfusion just after, we are like 1 minute after. Sometimes these kind of anesthesia are very, very fast. So the induction and the blood pressure drop are sometimes really hard.
Yeah.
So, because we want to go fast. So sometimes if we are able to do CBCT perfusion like 1 or 2 minutes after the anesthesia, we may witness this kind of problem. If we wait just a few minutes, it's too late. And honestly, I'm not sure that just a drop of the blood pressure for a few minutes will change completely the game. Honestly, I don't believe this. In Reims, we don't do a lot of general anesthesia. We are still much more performing under conscious sedation, right, for as much patients as we can. But finally, I'm kind of changing my mind, and now I really believe there's almost no difference with general anesthesia. Some of the very recent papers even favors general anesthesia because you get faster. So in a way, we don't know. If we want to have good insight on that, we need to decrease the X-ray dose of CBCT perfusion, and we can do 2 or 3 CBCT perfusion within a procedure. This will be the dream.
Right. Thank you. I think there's a question there.
How many CT acquisition is required?
If you need to, you need at least six acquisition. 1 with non-contrast, serving as a mask, and 5 with contrast. Usually, this is what we do with Philips, 6 acquisition. With Siemens, they do 11 acquisitions normally on the publications. So it's far more reliable.
Thank you very much.